A patient presents with severe hypertension, rapidly dropping potassium levels, and central weight gain. This multi-system collapse is driven by a massive, invisible hormonal flood. Standard diagnostic blood tests often fail here. Static hormone levels look identical whether the body is mounting a healthy, temporary response to extreme stress or housing a lethal, permanent tumor. This diagram shows the diagnostic challenge. A microscopic nodule in the pituitary, an occult tumor in the lung, or a mass in the adrenal gland can each output the exact same signal into the central bloodstream. To save the patient, physicians must look past the hormone levels and identify the specific cellular driver behind the secretion. This process requires the identification of biochemical autonomy, a state where a tumor has completely divorced itself from the body's natural regulatory mechanisms. Healthy regulation relies on the hypothalamic-pituitary-adrenal axis. The hypothalamus signals the pituitary, signaling the adrenal to produce cortisol, which loops back to suppress the initial signal. In an autonomous state, this stop signal is ignored, forcing continuous, uncontrolled hormonal output. Locating the source requires subjecting the axis to biochemical pressure and mapping the resulting spatial gradients. In clinical endocrinology, tumors are identified through systemic suppression testing and the application of diagnostic logic. The investigation begins in the retroperitoneum, at the primary factory floor of sterogenesis, the adrenal gland. The adrenal cortex is divided into three biochemical layers: outer zona glomerulosa, middle zona fasciculata, and inner zona reticulata. Each expresses specific enzymes acting as metabolic gates. The glomerulosa expresses CYP11B2, synthesizing aldosterone. The fasciculata uses CYP11B1 for cortisol. Because of this strict compartmentalization, a tumor will overproduce one specific steroid based on its layer of origin. Anatomy dictates chemistry. The hormone overproduced by a tumor reveals its geographic location within the gland. In Cushing's syndrome, the system is overwhelmed by a massive, sustained flood of cortisol. Step 1 is confirming autonomy. Physicians use the overnight dexamethasone suppression test, introducing a synthetic glucocorticoid to attempt to trigger the negative feedback switch at the pituitary. If morning cortisol levels remain high despite the dexamethasone, the normal feedback loop is confirmed to be broken. Step 2 utilizes ACTH levels to differentiate the source. Suppressed ACTH indicates an adrenal source, while elevated levels point to a central or ectopic driver. The dexamethasone suppression test probes the mechanical integrity of the brain's braking system. When ACTH is high, the source is either a pituitary adenoma, Cushing's disease, or an ectopic tumor hidden in the periphery. High-dose dexamethasone and CRH stimulation tests are then used to force the tumor to reveal its cellular nature. Pituitary adenomas often retain some receptor expression and will respond to massive dexamethasone pressure by suppressing their output. They also spike when stimulated with CRH. Ectopic tumors, like bronchial carcinoids, lack these receptors entirely and will ignore both high-dose suppression and hormonal stimulation. Escalating biochemical pressure forces the tumor to reveal its cellular ancestry. However, biochemical tests can be equivocal, and MRI scans miss up to 50% of pituitary microadenomas. To resolve these blind spots, physicians use the gold standard, inferior petrosal sinus sampling. Catheters capture blood directly as it drains from the pituitary, measuring ACTH before it dilutes into the general circulation. By comparing central ACTH to peripheral levels, a ratio of 2 or higher proves the pituitary is the source. A ratio below 2 indicates the excess ACTH is originating from an ectopic source elsewhere in the body. Mapping spatial gradients turns ambiguous symptoms into measurable vectors. This logic applies to Conn's syndrome, where the body is flooded with an excess of aldosterone. Screening begins by establishing an aldosterone-to-renin ratio greater than 750. Despite a scale of modern CT scanners, imaging alone is insufficient. Incidental, non-functional adrenal nodules lead to high rates of false lateralization. Adrenal vein sampling is required before surgery to ensure the correct gland is identified for removal. This requires navigating asymmetrical anatomy. The selectivity index uses a cortisol gradient to prove the catheter entered the adrenal veins. The final step is the lateralization index. An aldosterone to cortisol ratio of 2 or higher on one side confirms unilateral disease. This ratio determines the treatment path: curative surgery for a unilateral adenoma, or lifelong mineralocorticoid receptor antagonists for bilateral disease. Isolating the driver of Cushing's in the brain and cons in the adrenal gland relies on the same fundamental logic of spatial gradients. This shared numerical logic uses anatomical sampling to isolate autonomous secretion from the rest of the circulatory system. Systemic perturbation is mandatory. Static observation cannot expose an autonomous tumor. Once this rogue node is finally isolated and surgically removed from the body, the once chaotic hormonal flood comes to a complete stop. By utilizing biochemical blocks and mapping the body's feedback loops, physicians convert systemic symptoms into a targeted, curative surgical plan.